So good morning to everybody. My name is Dr. Patricio, and I will be speaking about the latest clinical evidence on the treatment of wet AMD patient. It is a great pleasure for me to be in the Indonesian Vitreoretinal Society meeting. These are my financial disclosures as I conduct research for several companies. These are my financial disclosures that you can see here. And in daily life, we treat patients based on the evidence that is generated by randomized clinical trials. And these randomized clinical trials show us that several of the drugs that we use, either ranibizumab or aflibercept, are pretty good for treating patients. But that appears to be happening only in randomized clinical trials. When we move to the real world treating patients, it ends up that we end up doing a lower number of injections and gaining a lower number of letters in vision. So that means maybe what happens here doesn't seem to be happening that much in the real world. This means we have an unmet need, an unmet medical need, a clear medical need. So patients need something better to be treated with. And that something better is brolucizumab. It is a small chain antibody fragment of only 26 kilodaltons that when we use it at 6 milligram dose, we end up getting 11 to 12 molar equivalent of what we get from aflibercept. That means a lot more binding capacity. Normally, we were used to treat patients with a full antibody. If we take the most important part of the antibody, which is the complementarily determining regions, which is these little red teeth that we have on top, and we change these and we place it on a single change antibody, we will be creating a new molecule, and that new molecule of a single chain antibody with the same CDRs that were created specifically for high affinity, that is called brolucizumab. What are the benefits of having a small molecule? It means I can put more drug into the same injection, and more drug probably leads to high penetration in the retina and more blocking ability of blocking the VEGF that sits inside the eye of our patients. And this is an example. If you use a fusion protein, which will be a 1-to-1 with certain proportion, this will be your blocking ability, and some of the VEGF will be activating the receptor, while brolucizumab, being a higher dose, a higher molar dose, 13 times higher, will be able to block a lot more VEGF, not permitting the interaction between the VEGF and the receptor. So this was tested, because what I've shown just now, that's only graphs, and this needs to be tested in humans in clinical trials. This is a phase 2 trial, and the black line represents the visual gains obtained with 6 milligrams of brolucizumab compared to in orange ranibizumab and in other colors the other doses of brolucizumab. This proves that the drug works, and it works very well regarding vision. Something else was done in phase 2, which is the following. If you treat a group of patients and take the time to evaluate when do they need a second injection, you will take 45 days to reach 50% of your patient needing another injection when treated with ranibizumab. That time is 75 for brolucizumab. This shows that there is higher durability. These two signs allow us to go forward and start testing these on a phase 3 trial. And that phase 3 trials were the Hawk and Harris studies. The Hawk and Harris studies are two twin studies, which basically are exactly the same, with a minor difference that within the Hawk, the brolucizumab 3 milligram was explored as well. These studies were conducted across the world. So you have patients from Asia, from Europe, from the whole of America, from Israel, Australia, New Zealand, and Japan. So a great diversity of patients were included in this study. So what is the design of the study? We did a loading dose for both drugs of 3 injections. Okay, as per label, the aflibercept was done 3 and then continued every 8 weeks, 1 injection every 2 months. For brolucizumab, the 3 loading injections was done, and then patients were attempted to be treated every 12 weeks, that is 3 months. Every time you see an eye over the number of the week, it means an activity assessment was performed. And each of the activity assessment will allow us to bring the patient down from 12 to 8 weeks if the patient needed so. The typical inclusion and exclusion criteria, meaning patients with an active lesion, okay, with a wide range of vision, 23 to 78 letters. And the exclusion criteria was, of course, not putting in any patient with fibrosis or geographic atrophy. So what was the disease activity criteria that we used? At week 16, early on in the study, it was based on visual acuity and OCT. Later on, it was mostly based on visual acuity only, and this was repeatedly done across the first and second year of the study. So what was the amount of patients that managed to complete this study? And this is something very important to look at. And we can see that well above 80% of the patients managed to finish the study. This is a good sign that the patients tolerated the treatment really well, and most of them completed the 2-year treatment of the study. What are the baseline characteristics? We need to make sure that before we start the treatment, all patients in the 3 groups of brolucizumab or aflibercept have more or less the same characteristics. So they do have the same age, they do have the same proportion of females, they do have the more or less very high, quite high, above 60 letters of visual acuity, types of lesion, everything. This means the 2 groups that we will be comparing, the only difference they have is the treatment that they receive. All the other parameters are exactly the same. What was the primary endpoint of the study? This was a non-inferiority study looking at the difference in vision between brolucizumab and aflibercept. The non-inferiority margin was set by the FDA at 4 letters. So let's look at the vision-related outcomes first. Let me remind you that when we evaluate visual acuity in a clinical trial, we tend to use the ETDRS chart, not the typical Snellen chart that we use at the clinical setting. For these studies, we use these, which has 5 letters per line. So gaining 15 letters means going from here, gaining 1, 2, and 3, so that means 15 letters. Gaining 15 letters of vision has a very positive impact in the quality of life. So these are the results of the evaluation of the visual acuity. You can see that for brolucizumab and aflibercept, the visual acuity was the same, non-inferior, for the 2 studies. So highly likely, vision is related more to the type of lesion rather than the type of drugs that we may use. So we may see this ceiling effect very often with other studies, with other drugs as well. The vision that we get is the same, it means non-inferior. But let's look at something that is very important. We said that gaining 15 letters is a big leap in quality of life for a patient. And we can see the following. The proportion of patients that gained 15 letters or more was higher for brolucizumab than for aflibercept in the HOG study. It was the same in the HIRIS study. But this means that in the HOG study, 1 every 4 patients will gain 15 letters or more, while here with brolucizumab, it's 1 every 3 patients gaining 15 letters or more. What about the big losers, those patients that lose vision despite of the treatment? And it was similar across the board. There were no differences, and it was similar the result in the 2 studies. What about the anatomical efficacy outcomes? Now we're looking at the OCT results that we find. And what is very interesting to look at is the patients treated with brolucizumab immediately after the first injection showed a more dramatic drying of the retina. This is in the HOG study, and you can see it a more smooth and maintained over time compared to the typical sawtooth pattern that we see when we treat patients with a fixed regimen of bi-monthly aflibercept. So at any time point, the dryness of the retina was better for brolucizumab, apart from this one. For brolucizumab, much better than aflibercept. So dries the retina better than the aflibercept. And this was again seen in the HIRIS study. So it's the same situation for the HIRIS study. Both studies showing a higher drying proportion. So it's interesting to look at something that is the amount of intraretinal fluid, which is the one that we want to look at, and the subretinal fluid at weeks 16, 48, and 96. And what we can see here that any of these time points, the proportion of patients with any of these fluids was lower for brolucizumab in the blue bar compared to aflibercept in the gray bar. So we can say that at the beginning, half of the patients will still have fluid for aflibercept, but only 1/3 of the patients will still have fluid for brolucizumab. And towards the end of 2 years, 1/3 of the patients for aflibercept will still have fluid, and only 1/4, 1 every 4 patients will have fluid for brolucizumab. And it's the same situation for the HIRIS study. Another thing that was interesting, it was the assessment of activity by the masked investigator. So we, without knowing whether the patient was being treated with A or B, were to decide whether a patient at week 16 was either active or not active. And most of the time, patients with brolucizumab, only 1 every 4 was considered active, while 1 out of 3 were considered active for aflibercept. Same situation in the Harris study. So we, investigators, without knowing the treatment arm, we would say that the patients were less active in the brolucizumab than the aflibercept. So let's move on to the Q12 status, dosing status, and predictability. How do we use this drug in the real world? First, let me show you the proportion of patients that were maintained across the first year on a Q12 3-monthly injection, and that was 56 and 51%. So that it's more than half of the patients were maintained on Q12 dosing. So how do we predict whether a patient will be maintained? Do we have to look and do all these assessments in real life? Highly likely not. If you do your loading phase and then tell the patient to come back 4, 8, 12 weeks after the last injection, 3 months after the last injection, and do your disease assessment there, you will bring some patients down to 8, but the majority will continue in a Q12 treatment. And that means that you have an 85% chance of maintaining your patients in the same treatment regimen for the first year. So it's very highly predictable that whatever decision you make here at week 20 maintains through the first part of the study, through the first year of the study, and it will be the same in real life. What about for the second year? Well, for the second year, your predictability is 80 and 75% in the Hawk and Harris studies of maintaining whatever decision you make there at the end of the first year to be maintained for the second year. So highly likely we will be doing assessments at week 20 and then every year after that, and keeping patients either at 12 weekly or bringing them down. Bear in mind the following, that in this study, going down from 12 to 8 was allowed, but it was not allowed to go back from 8 to 12 again. Nobody could go back up to 12. And that is something that we normally do in clinical practice. And we would have seen much better numbers of patients being treated every 12 weeks have we done that. So in real life, we will see a lot more patients being treated every 3 months. What about the safety outcomes? A lot of things were said regarding safety, but let me be clear with this data. Because of some safety signals that were found and were further commented on the real life use of the drug, Novartis decided to put some clarification and transparency to the evaluation. And because of this, created a safety review committee to look at the data from the clinical study and also the post-marketing data that we may discuss in the Q&A session. So specialists from around the world, 5 from the US and 3 from Europe, plus 1 observer from the ASRS, made the members of the safety review committee. They had full autonomy and full access to all the data to release the final message of what happened during the study. And this is what they came up with. 4% of all patients treated with brolucizumab had some sort, any kind of inflammation. And it was 1% for those patients being treated with aflibercept, 1 versus 4. And this roundup of 4 and 1 was done by the FDA, not by the committee. So let's look at these 4% of patients that had any sort of inflammation. What is interesting is that you get 4% of any kind of inflammation, but 3% had inflammation plus the vasculitis, which could be far away from the fovea, but still it's a vasculitis. 2% had both the inflammation and vasculitis plus any form of vascular occlusion, but only 1% of the patient had vision loss associated with these. And this is what the patients and doctors care the most about. What is the proportion of patients losing vision? So we can look this in detail, and we can see that almost the majority of patients either maintained or gained vision. 23 of the patients with inflammation also gained more than 5 letters. 12% maintained either plus less 4 letters from baseline, and only 14 of these patients ended up losing some form of vision. But we may look further into this and see what happened with the other arm of the study, which is the aflibercept arm. And we can see when we do the comparison of patients losing 5, 10, 15, or even more than 30 letters, that the proportion of patients losing vision is the same for brolucizumab and aflibercept: 16, 11 for 10 letters, 7 for 15, and 2 and 3 for losing 30 letters or more. And if you ask me the reason, well, inflammation may play a role here, but lack of efficacy plays a role here. So the proportion of patients losing vision, important vision, 30 letters or more, was the same for aflibercept and brolucizumab. So we may come with the final conclusion that the visual outcomes, the visual acuity achieved with brolucizumab was not inferior to aflibercept. Anatomical outcomes, brolucizumab dries the retina much better than aflibercept at any time point, week 16, 48, or up to 2 years. The disease activity evaluated by somebody that is masked to the treatment was much better for brolucizumab, showing less patients considered active at week 16. The Q12 treatment interval every 3 months, it was maintained for more than 50% of patients being treated. And if we were allowed to bring patients from 8 to 12, that number would have been much bigger. Now, predictability is very good. It's 80% for the first year. So that means if you look at your patients at week number 20, you have a certainty of 80% that that patient will be okay to be maintained every 3 months for the first year. And safety, we can discuss this in detail, but it overall exhibited a well-tolerated safety profile. So thank you very much. We have a lot of extra data, but we don't have that much time. We could discuss the PCV sub-analysis and further data regarding safety from the real world in the Q&A session. Thank you very much.